I am Liz Powell, and I am one of the co-founders of the Women's Digital Health Network, as well as co-founder of G2G Consulting. And I am super excited for today's event for the Women's Digital Health Network. We have amazing speakers joining us today. And before I pass to my co-founder, Netta Hanafi, I just wanted to give a little bit of an overview. The Women's Digital Health Network was started back in March. We are focused on that intersection of women's health and digital health. And what we are trying to do is create this network of folks in industry to come together as one voice to educate and influence policy and regulation at the federal level. So we have been meeting over the past several months. We've got a strategic roadmap for what we're going to be doing. We're next working on some position statements, or what we call white papers. And once we have those established, we'll start to do our outreach to meet with elected officials, with regulatory agencies, and organize more events. And so we would love to have more people join the Women's Digital Health Network. So we welcome that. You can just go to our website and join there. Listen today, and hopefully by the end of today, you'll see how valuable this network is. So our first speaker, really the keynote speaker, I am not introducing her, but I have known her a while, so I have to say a few things. Dr. Sophia Yen is one of the most driven, effective force for good I've ever worked with. I had the pleasure of working with her when we launched the Women's Health Innovation Coalition several years ago, right before COVID. She is just an inspiration. So I'm super touched, super excited that she could give us time today to speak today. So I just had to throw that in there, even though that's not my official role. My official role is to now pass it over to Netta, one of my co-founders.
Thank you, Liz. Your official role can be whatever you want it to be. So, as Liz said, thank you and welcome. We're really excited about today's conversation, and it is my honor and pleasure to introduce Dr. Sophia Yen, MD, M.P.H. She's the co-founder and chief medical officer of Pandia Health, which is the only doctor-founded and women-led online hormonal women's health clinic, providing both prescription birth control, menopause, sexual wellness, and acne services. Dr. Yen was named as one of Inc.'s 2023 Female Founders 200 and as the 2023 Entreprenista 101 Changemaker of the Year. She has more than 20 years of experience in medicine and graduated with a BS from MIT, an MD from UCSF Medical School, and MPH from UC Berkeley in maternal health. She serves as a clinical associate professor of pediatrics in the Division of Adolescent Medicine at a prestigious academic institution and has co-founded three nonprofit organizations and projects in her endeavors to improve the lives of women. The Trust Women Silver Ribbon campaign, SheHeroes, and the FFL movement are all part of her three nonprofits. So, Dr. Yen, please join me on camera. I am going to turn it over to you. I know you have some slides to share, and we also have an additional speaker at the end where we're going to be welcoming your questions and engaging in a dialogue. So thank you, and I'll get off camera. Take it away.
Hi, everyone. Thank you so much for joining today. And we are so lucky to have Dr. Culver, who is one of our two menopause leads at Pandia Health, at the end to answer any questions, though not personal, but general, about menopause. She is one of the few Menopause Society certified practitioners in the country. Know that there's only about 2,000 of them, and Pandia has 5. But we also have Dr. Culver and Dr. Hansen, who have 20+ years experience each, are both OB-GYNs, and just a wealth of information. So I'm going to launch into my talk, and I'm going to speak at the speed of a New Yorker because I originally had 45 slides and I cut them down to 25. So we'll cover women's hormonal health from periods through menopause, all in the span of the next 20 minutes. Number one, for birth control, make sure, given the current political events, that everybody optimizes their birth control and knows all of their options. So one way to test yourself and test your physician is imagine all of the birth control methods, rank them from most effective to least effective, and include the permanent methods, because a lot of people, including physicians, will get this next question wrong. Ready? Ta-da! Implant beats vasectomy. That always blows my mind. Vasectomy is a permanent, non-reversible, and, well, maybe reversible, but vasectomy is pretty permanent birth control and is the gold standard. But something that goes in your arm beats the vasectomy in its efficacy of preventing unplanned pregnancy. Here on the bottom right is a CDC handout. The implant fails 5 out of 100,000 people that are using it at a year versus vasectomy, 15 out of 100,000 people. So it is 3 times better than the vasectomy. Next comes the IUD with hormone, which has a 2 out of 1,000 failure. And that beats tubal ligation, which has a 5 out of 1,000 failure. And tubal ligation is snip, snip, take out an inch and burn. So it always blows my mind that anyone can get pregnant on tubal ligation, but your body must be very fertile. But IUD with hormone beats that. Then comes the copper IUD. The negatives of that, just make sure people know the 2 major side effects is more blood, more cramps. And so if you're a person who doesn't notice your period when it comes, you are the perfect candidate for the copper IUD. But if you're like me and you feel every blood drop creeping down, no, maybe not for the copper IUD. Then comes the shot, the ring, the patch, the pill. The ring, we believe, beats the patch, beats the pill, simply because you only have 13 times a year that you can mess up on that one. There is a 1-year ring, but we only recommend it for those 30 and above because it has low estrogen, and I'll cover that later. The patch, you have 52 weeks that you could mess up on. The pill, you have 365 days you could mess up on. And then condoms, we always recommend in addition to all of these methods, because it and masturbation and abstinence are the only ways to prevent sexually transmitted infections. And even then, the condom is imperfect. It doesn't cover the entire surface, which you could transfer scabies or other STIs. Important for people to know that when you see something new, particularly because we're innovators and startups, that the latest may not be the greatest. I always thought, oh, it's the newest thing, it must be the best thing. Sometimes it's just the thing that came out. And so one example is Phexxi, which has like a 15% failure rate versus spermicide, which is 21% failure rate, but its price differential is like $200 versus $10. Another example is the over-the-counter birth control. Certainly the O pill, which is a progesterone-only pill, Norgestrel, is the most effective over-the-counter option that people have. But as I like to say, if you have access to a prescriber, please continue with your current method, because estrogen progesterone pills have a lot more benefits than a progesterone-only pill. And progesterone-only pills are great if you're a breastfeeding woman, because you don't have estrogen, which would affect the breast milk supply, and for smoking, vaping women, because it doesn't have the blood clot risk as much as an estrogen-containing birth control pill, your normal birth control pill. However, this is my public service announcement, one of several today, or maybe the only one. That if you are late by 3 hours taking the O pill or general progesterone only pills, and you had sex in the past 5 days heterosexually, you need emergency contraception if you want to prevent unplanned pregnancy. And then you need to wait 2 days, abstain or use a backup method, condoms, until the hormone builds back up. And so it would be horrific if a ton of young people are like, oh, all pills are the same. There's this new over-the-counter birth control pill. I don't need to see my doctor. I'm just going to switch to that. And then they go see Oppenheimer, and then they will be literally screwed and pregnant. So it's really important for people to know that this progesterone-only pill has a 3-hour window, and people need to be educated, and people need to know this. Know that the formulation was approved in 1973 before a lot of these young people were born and was taken off market in 2005. Not because there was anything bad or evil, but simply because everything else was better. So again, if it were me, my daughter, my friend, my patient, anyone with access to a prescriber, and Pandia Health can prescribe in 15 states and we can deliver to all 50, and we encourage birth control tourism and we only charge $30 once a year, then I would use something I could get from a prescriber and have access to all 40 different birth control pills, the patch, the ring, and if you can see a provider in person, the implant, the shot, and the IUD. There is another pill that's coming over the counter. It's 20 micrograms of estrogen. I'm an adolescent medicine specialist, and I can tell you that Stanford Pediatric Endocrinology, Stanford Pediatric Adolescent Gynecology, Stanford Adolescent Medicine all recommend 30 micrograms of estrogen until you're 30 years old. So oftentimes the patient will come in and they'll say, give me the lowest amount of estrogen possible. And the doctor will be like, okay, that sounds good. And then what they don't realize, this is not good for their bone health because you want maximum, well, minimal, enough estrogen to support bone health until 30 years old. And then after that, you can do what you want with respect to birth control pills. And we'll talk about menopause later. And so a whole bunch of people are at age 50 or 60 are going to fall down the stairs and break a wrist, break a hip because they didn't realize they were on too low of estrogen. So 30 micrograms of estrogen until 30 years old. So this pill is great and it has estrogen and progesterone and it's an OG form of birth control. However, not good for those under 30 years old who I think might be the #1 people to go for an over-the-counter birth control pill. Re-emphasizing, get the good stuff. Birth control best practices, another way to check if your doctor's up on the latest and greatest. We have, the reason I don't have it in presentation mode is because I'm OCD and I have to get through these slides and I have to see how fast I need to speak. So that's why, but hopefully it's good enough. To check if your doctor knows their stuff is if your birth control pill has the 3 letters TRI in it. That means that your doctor's not up on the latest and greatest. At most academic institutions are teaching people that you give them a monophasic pill. The triphasic pill is up and down, and not really necessary. I already told you about estrogen, 30 micrograms, and then what is the best birth control pill to start on? I developed an algorithm for Pandia Health that better serves all women, but more so those of Asian, Black, and Latina descent, because I realized as a woman of color, what we're teaching in all the schools is great if you're a Caucasian female that wants to bleed every month. But if you're of Asian, Black, Latina descent, spoke to my fellow Asian, Black, Latina doctors, and we're like, oh yeah, that pill we're teaching the medical students does not serve our people. So I took all 40 different birth control pills and ranked them. Most likely to bleed, least likely to bleed. Most likely to have acne, least likely to have acne. Most likely to have zits, least likely to have zits. Took the one that we were taught in medical school and optimized it. And with that, at Pandia Health, we do a 10-week follow-up for newbies and those that are new to #periods optional. And 94% of our patient at 10 weeks were like, you good? You want to change? 94% are like, I'm good, let's stay with this. And then to further show how good our algorithm is 82% are still using our services at a year versus the standard 33 to 55%. Know that the top 3 reasons for missing a birth control pill is forgot and away from home. And this can be solved with an alarm. We all have cell phones. I have a colleague who came up with a birth control holder. You should check it out. You slide it in, you slide it out. If you don't pop out the pill by a certain hour, you can have it text or call your phone until you do. Away from home, I always have an extra travel pack in my backpack, in my purse, and where I have my toothbrush. Know that in general, insurance will give you an emergency pack. Also know that if you have to pay for it, it's sometimes $7 a pack, $15 a pack, totally worth it for #peace of mind. No new pack. Know that in 20+ states, the insurance is required by law to dispense a year's supply if your doctor writes it so. Most doctors don't know that you can write for a year's supply. Educate them that they can. As a doctor, I was like, oh, dispense 1 refill times 12. I gave you a year's supply. What are you complaining about? Now that I'm in the business, I realize I have chained this woman to the pharmacy every single month. A pharmacy can restrict a prescription if the insurance doesn't want to cover it, if a patient can't pay for that many packs, but they cannot expand it. So educate your physician. They can dispense 13 packs for a year or 17 packs if you're skipping the bleeding week. And then the whole point I started Pandia Health was no one should run out of birth control on our watch. And so we can deliver to all 50 states. If your doctor prescribes it, you have insurance, and then you pay us nothing because thanks to the Affordable Care Act, no copay, no deductible. However, we also have cash options. And then these are the states that we can prescribe in, and we encourage birth control and menopause tourism. So if you can get to one of these states and say, hey, I'm at JFK right now, or I'm at one of the Disneys, or Vegas, or South by Southwest, but I'm normally not in a state that you can serve. Our doctor in that state can serve you while you are physically in that state, filling out that questionnaire, paying for that prescription, and then we can ship it to all 50 states. Given the political situation that we have going on right now, want to make sure people know that birth control is not just birth control. 70% of women on birth control pill, patch, ring are on it for other reasons. And you can use hormone therapy, aka birth control pills, to level the playing ground and make women equal to those without uteruses and not have to bleed 1 week out of 4 randomly. And then you can decrease your risk of cancer, you can decrease your pain, and you can decrease your risk of anemia. So financial, educational aspects of bleeding 1 week out of 4 painful periods is the #1 cause of lost work and school under the age of 25. A lot of women miss school because of painful periods. And then anecdotally and academic competitiveness, I was a pre-med MIT biochem final, all of a sudden, bleh, blood. And I'm like, do I run to the bathroom or do I finish the exam? And all of you who are pre-health here, you know the answer. The answer is you finish that exam. But I looked to my left, I looked to my right, 2 people without uteruses, not a care in the world. And then I realized 1 in 4 women in that room that day was bleeding. And so as a feminist, I like to say I can do anything you can do bleeding. But as a doctor who believes in drugs and science, why? Why bother? And then for sports, there was a Chinese Olympic swimmer. She came out of the pool and she's like, ugh, I think I missed a millisecond because of a cramp. And I was like, who is your doctor? Because if I were your doctor, there is no way you'd be bleeding anywhere around the Olympics. And same for the US soccer team. Things that are better with stable hormones rather than up and down every month, or 3 weeks up, 1 week down, are acne, arthritis, depression, diabetes, seizure, anything period related. If we put you on the pill, patch, ring, the bleeding is much less, or we can make it go away completely. And so you no longer have painful, heavy periods or PMS. And then the #1 cause of anemia in a menstruating woman is menstruation. Every time you build up that lining, you risk endometrial cancer. Every time you pop out an egg, and we don't know if it's a popping, the healing, we feel it has something to do with the tube, you risk ovarian cancer. And if another way to quiz, if your doctor knows their stuff, how do I decrease my risk of ovarian cancer? If you go on the birth control pill, patch, or ring for 5 years, you decrease your risk of ovarian cancer by 50%. There is no other way to decrease your risk of ovarian cancer right now other than taking out your ovaries, which we wouldn't recommend until after menopause. And even then, I don't know, but definitely take the ovaries and the tubes if you're decreasing ovarian cancer. And then lastly, I love colorectal cancer to bring up simply because it educates people that the uterus is going up and down every month. The colon is around it, and the colon, I feel, is sympathetic. And it's like, oh, I am sorry that you're bleeding. And so it can either run faster, diarrhea, or it can slow down and give you constipation. So 30% of people who menstruate are having these symptoms, but it affects the colon and therefore increases your risk of colon cancer. And then the whole point is I'm trying to pitch to you that you don't have to bleed every single month unless you're trying to catch an embryo. And most people are not trying to catch an embryo, get pregnant until 26 on average in this country, or 35 for those of us who had to get through more school or took a while to find our significant other. Know that normal human biology is fewer menses, and Dr. Beverly Strassman, an anthropologist, studies the Dogon tribe of Mali, Africa, where they're banished to the menstruation hut. A talk for another day, but In summary, the Dogon tribe, who dies at the same age we do, so we are comparing apples to apples, has 100 periods in their lives. We have 350 to 400 periods in our lives. We bleed enough for 3 other uterine-bearing people. And mainly, they have 8 to 9 children. We have 2. How many periods you have when you're pregnant? 0. They breastfeed exclusively for 12 months. We breastfeed 0, 3, or 6 times 8 or 9 children. How much bleeding do you have when you're exclusively breastfeeding? None. And so it's more natural to be pregnant or breastfeeding instead of this incessant menstruation, which puts us at risk of ovarian, endometrial, colorectal cancer, as well as anemia. And if that doesn't convince you, environmental, though certainly a lot of people are using reusable menstrual products, and kudos to you. So if you want a recap of that part of the talk, please go to pandiahealth.com/periods optional. So this is what I think you need to know about peri and menopause briefly. I would love to talk more, but we only have limited time. And we have Dr. Culver, the goddess of one of the several goddesses, but our personal goddess, in addition to Dr. Hansen, of menopause, here today to answer any of your questions. So 1, know the definition so we can be talking about the exact same thing. Technically, menopause is the day of your final menstrual period. And just so you know, in medical school, I graduated 30 years ago. And what I was taught is you put your hand on the woman's shoulder and you go, this will pass, AKA suck it up. And now I'm learning that, on average, you can have perimenopause, menopausal symptoms for about 7 years. And that 70 to 80% of people are having hot flashes. Would you ever put your hand on a dude's shoulder and be like, suck it up, ha ha ha, for 7 years? No, this is unacceptable. Hashtag stop sucking it up. We need to ask for the right treatment, ask for the research, and get it treated. And the other horrible part for those of you on this call who don't have uteruses is that we don't confirm menopause until 12 months after the final menstrual period. So as a person approaches this, we have a period and like, ooh, is this the last one? And then 3 or 6 months later, oh, we got another period. I guess it wasn't the last one. And you got to reset the clock again. Very irritating, very annoying. Good number for people to know. The median age of the final menstrual period is 52.5. And those of us born with uteruses spend 40% of our lives in postmenopause. So don't write off the period that's postmenopause. And greater than 60% of us will survive until at least 80 years old. Know that perimenopause is the part that leads up to that final menstrual period, and then everything after that is postmenopause. And perimenopause is irregular periods, fewer periods. Postmenopause is everything after that final menstrual period. Symptoms of menopause, I think you all know, but know that there are a lot of them and that it can present in interesting ways. I went to my physician and my triglycerides shot up and then my waist disappeared. And she's like, oh, you need to talk to the nutritionist and do more exercise. And, it's part of old age. And I realized old age is a euphemism for menopause because we now know that when you take away the estrogen, bad stuff happens to your cholesterol, but more importantly, central adiposity. So if you know me, 95% of my wardrobe is skirts. And all of a sudden, my skirt didn't fit. And I hadn't changed my diet. I hadn't changed my exercise. I'm actually an obesity expert that counsels patients on exercise and diet. So I know. And the year before, it had been perfectly normal. All of a sudden, this all goes away. I went from my birth control pills, switched over to HRT, and then my waist came back. Oh, thank goodness. But this central adiposity situation is bad for your health because it's reflecting visceral deposition of fat, which increases your rate of heart attacks, etc. So it's really important to realize that estrogen therapy helps the blood, the brain, and the blood, I like to say, because I love alliteration. However, know that the only FDA-approved reasons for hormonal therapy are genital urinary syndrome of menopause with urinary frequency and sometimes painful peeing, and then vaginal dryness, painful sex. I call it sandpaper vagina, fragile vagina, vulva as well. moderate to severe hot flashes, moderate to severe night sweats, and at risk for osteoporosis. What you don't see here is prevention of dementia. What you don't see here is prevention of cardiac disease. And I asked the community, like, what will it take to get that indication? Because as a telemedicine company, we are being scrutinized. People are being put in jail for going outside the guidelines. And on a one-on-one, you can ask your doctor to go outside of these, but online, this is what we're limited to be safe, so we don't get sued, because we're in America and people like to sue. But the whole reason we started this estrogen therapy in the early days was because we noticed that women had a 10-year delay in their cardiac events. So it's just huge to me that we can't use it for cardiac prevention, that people say there isn't enough evidence, but I think there is personally. Top 3 books. I don't get any money from these people. I just love their books, and I am huge fans of all of them. The New Menopause by Marie Claire Haver. She's most famous for the Galveston diet, which to me is pretty much the Mediterranean diet. And then Estrogen Matters by Dr. Blooming and Dr. Tavris. Dr. Blooming is an oncologist. If your doctor's like, oh, I need to put you on the lowest amount of estrogen for the shortest amount of period because breast cancer, give them this book. It goes over the Women's Health Initiative and all of its flaws, and why estrogen is not being shown to increase your risk of cancer. And in fact, those who study molecular biology are thinking that it may actually decrease your risk of breast cancer. And I think I hit it on another slide. The Menopause Brain Love, Dr. Lisa Mosconi, a PhD researcher doing MRI PET scans on the brain before and after menopause, showing that those who have more estrogen receptors, meaning the brain is hungry for estrogen, not having enough, is associated with decreased mental function. So key medical info that I've taken out of my menopause journey thus far is really want everyone to know that estrogen most likely does not increase your risk of breast cancer. Those on the estrogen only arm of the Women's Health Initiative had a decreased diagnosis of breast cancer by 23% and death from breast cancer by 44%. I always say, how do you know what's the best treatment? Ask the doctor. What are you using? Most providers lean towards transdermal patch gel spray bioidentical estrogen because it avoids the liver, which might increase blood clot risk. And then know that progesterone is there to protect the uterus from endometrial cancer. If you have had a hysterectomy, then technically you don't need progesterone, but it can also help with sleep. And then lastly, I know I'm running a couple minutes, but I have to take point of privilege. This is my wish list of policies to improve women's digital health and increase access. As a telemedicine provider, the barriers to expanding telemedicines that physicians and other providers have to be licensed state by state. Doctors, we take a national exam, and medicine should be practiced the same throughout the states. So to make me apply every single state by state is a waste of my time and a huge barrier for access to experts from Stanford, UCSF, etc., all the academic institutions to reach places that may not have that quality of doctor or that specialist. Medical boards and states are currently, some of them, 10 of them that Pandia Health cannot get into, requiring synchronous visits for all telemedicine, phone, video. And the reason we're able to charge $30 is we don't have to do a synchronous. As you can tell, I run Yappy, and the most expensive part is the doctor's time. And so I can't cut patients off after 10, 15 minutes. An asynchronous platform, research has shown people are more honest about questions like, when was your last period? How many partners did you have? Are you sure you're not pregnant? If you don't hear my voice or see me on video, fear judgment by a physician. And then birth control should be over the counter anyway, and the risk from hormonal therapy is even lower than the risk from birth control. So I hope that we can convince them to make exceptions for birth control, acne, menopause, and whatever else more, rather than one blanket treatment for everything, thereby decreasing access to amazing health services. And then for menopause treatment, educate you all again that version 1 or vagina 1 was Obama-Biden under the Affordable Care Act, no copay, no deductible for any FDA-approved birth control. It just seems logical that we should have V2 with the first vice president of menopausal age and the hopefully future president of menopausal age, that there would be no copay, no deductible for any FDA-approved treatment for menopause. And if you can't pass that, then you are sexist and ageist. Know that there's no required menopause training in medical school. States require various specific topics of CME in order for me to get my license there. And medical schools should have at least 1 hour of menopause training. I think we could pass that as a national law. Though as a doctor, I could see it would be really annoying if you start passing law by law. But this one, I feel we should make the exception. And then OB-GYN, internal medicine, family medicine should have at least 3 to 5 hours. Let them figure out what they feel the minimum should be of menopause training. But they just did a survey today, not 30 years ago, but today. And the OB-GYNs that are graduating today, 31% have some menopause training, but 69% do not. What does that mean for internal medicine and family medicine? I don't know. Even worse or possibly better, but I doubt that. And so again, know about the Menopause Society. They are a nonprofit. They are the great organization certifying and educating providers about menopause. And then lastly, we need more funding for women's research, both with respect to drugs, with respect to race, ethnicity, response, genetics, all sorts. And know that women's health is not just we call the bikini spots, but brain, heart, bones, all of that. So that's me speeding it up, and know that we have Dr. Culver here to speak as well. And I will stop sharing. I hope.
Wow. You did speak like a New Yorker, super fast, but that was amazing, amazing information and a lot to cover. And the questions have been coming in. But with that, I'd also like to invite Dr. Stephanie Culver, and I'll give a quick overview of Dr. Culver, who is an MD, MA, FA COG, MSCP, and is a board-certified OBGYN and Menopause Society certified practitioner, which Dr. Yen spoke of. She's a mother of 5. She has learned from and reflected upon her experiences to help other women through their own challenging times, and understands the many roles and responsibilities women of today have. Dr. Culver practiced full-scope OBGYN for over a decade in her home community in the LA area before switching to helping more people via telemedicine. She graduated from UC Santa Barbara for undergraduate and graduate school, the George Washington University School of Medicine and Health Sciences for her MD, and the University of Minnesota and Hennepin County Hospital in Minneapolis for her OBGYN residency. She returned to Southern California and established a private practice where she delivered babies, performed surgeries, and provided clinical care until she was pregnant with her 5th child. For the last several years, Dr. Culver has been practicing telehealth at Pandia Health and is helping spearhead its evidence-based expert care for perimenopausal and menopausal health. Thank you, Dr. Culver. And again, thank you, Dr. Yen. What a powerhouse of ladies that we have on the call here. And I'd just like to, welcome you, Dr. Culver, to have it, if you have any comments, and maybe you can dive into questions because there's quite a few.
Yes, thank you so much for having me. I'm always amazed when I hear Dr. Yen speak about the jobs that we continue to have to do, right? There's so many women that need our help, and telehealth is one of those possibilities to break down the barriers that women have. And we are still so behind on reaching women that would qualify and that would benefit from menopause hormone treatment and also contraceptive care as well. So it's always inspiring to be here and to hear of Dr. Yen's work, of course.
Of course. Well, thank you. And I'm so pleased that we could have you both here to maybe answer questions from our wonderful attendees that they've been posting in. One of the first ones that came in is that given that there's evidence that HRT treatment during perimenopause is helpful, but one doesn't know the symptoms alone that they're in perimenopause. Are there specific blood tests that can remove worries about mistreatment before prescription for HRT?
That's a very good question. So there have been so many experts that have gone over our hormone testing, is hormone testing really, first of all, reliable from day to day? And secondly, do we really need to expend that healthcare cost? And number three, let's not forget the obvious. Like, we know the average age of menopause for most people, and it can change with ethnicity, of course, but it's 52. And prior to that, we know it's about 7 to 10 years that women experience and perimenopausal symptoms. We also know that women have had difficulty with fertility at mid-30s. So of course that's ovarian function. So when ovarian function starts to be compromised and decline is when really we're starting to see symptoms and symptomatic responses. So really it's the physician's job to ask these questions too of their patient, like, are you having symptoms? And there's about 30 to 40 and probably even more, but being prepared for a visit, there may be questions that prompts a woman to say, hey, I have this. So education is very important. Public service announcements is super important so that women, when they arrive to their physician, or if they access a telehealth service or a platform, knows the language that they need and to have a vocabulary of their symptoms.
That's super helpful, Dr. Culver. And it's empowering yourself to ask the questions. You're the best knower of your own body, right? And what you're feeling. And I think what you're saying as well is having the space with our practitioners to have those honest conversations. And it's a journey. It's not a destination. So it's a process. So thank you so much. Anything to add, Dr. Yen, there?
I think it's just important for people to realize a lot of people will come to our platform to treat their perimenopause. And so when you're in front of the final menstrual period, you are still at risk for pregnancy. And we can give you hormonal therapy to treat the symptoms of perimenopause, which are similar to the symptoms of menopause, but it may come in the form of a birth control pill or a birth control ring. Do not be upset or angry, because we have a lot of patients who are like, I came here for hormonal therapy. Why are you giving the birth control pill or ring? It's simply because it has the estrogen and the progesterone all in one, and it is a nice delivery mechanism, and it also prevents unplanned pregnancy. So if you're not at risk, we could, add hormones, but also when people talk about labs for menopause, we don't treat by labs. We treat by symptoms. And I had a graph that showed your hormones around perimenopause, and the graph is this, like an earthquake. And so I do not like to add estrogen on top of, certainly if it's low, oh yeah, that'll help. But if it's high and I add estrogen, that's not a good situation. And so if I take it over with the birth control pill, patch, ring, we avoid the patch for perimenopause because it's a higher dose estrogen, then I can calm it down until you get to post-final, then we can add back when the levels are low and stable, as opposed to this chaos of perimenopause. And I personally believe going into menopause on a hormonal birth control where your hormones are taken over and smooth is going to be a much smoother ride. The analogy I just have to share, because I have my images I have to share with people, of menopause in my brain is like running out of gas. You can run out put, or put. And that also allows me to bring up flooding, not a doctor term, but a known term. If you say, heavy bleeding, I've had 2 friends personally. So this is not like I heard blah, blah, blah. 2 friends, maybe 3, tell me that with menopause, perimenopause, because it was bleeding, they had horrific bleeding, flooding like you've never seen. She couldn't visit any friend for a month for fear of destroying people's furniture. And I was like, oh my goodness, if this had happened to me once, I would have run to the doctor. So please, ladies, # stop sucking it up. If you have one flooding, go see the doctor. Don't be suffering for this for the next month or whatever. It's just, you don't have to. We have stuff to take care of that.
Stop sucking it up. I love it. And I know, Dr. Yen, you were busy responding to a few questions online, so you can track those. But there's another question that also talks about, I'm not sure if either you, Dr. Culver or Dr. Yen, are aware of a recent article, and it links musculoskeletal syndrome of menopause. Any thoughts there?
Yes, that is a very good topic to bring up. So again, this is women started to notice when they took menopause hormone treatment, their skeletal system or their joint pain would improve. And we do know that estrogen and estradiol have anti-inflammatory properties. So it's really a blanket type of treatment that can help women that even come in with non-specific joint pain. In general, we do follow guidelines for indications of treatment. So I hope with time and with more studies and more research, Dr. Yen has described it, that we can have more indications for using menopause hormone treatment and estrogen. But joint pain and musculoskeletal symptoms, along with a myriad of other symptoms, are helped with estrogen. So yes, that is correct.
The positive,
Mhm.
another silver lining. Anything to add, Dr. Yan?
I want to make it clear that estrogen is the gold standard and beats everything else out there, because people love to ask about supplements. And when you take a supplement, to me, one, know that they are not FDA regulated. They are not FDA tested. There are probably some reputable places that are tested outside, but the FDA does not regulate or test these things. And the example I give is you go to GNC, you buy a bottle of what's the 5-HT one that people take, but it says 100 milligrams on it, and they've tested that one bottle. I don't understand if different batches, but even then shouldn't have different doses. But in that same bottle, they found 10 milligrams and they found 1,000 milligrams for something that was labeled 100 milligrams, because no one is required by law to test this. But also that I love Dr. Mosconi's book, because she goes through the supplements and what evidence there is and what evidence there isn't. And so for all the supplements, they have a little effect. But do you want something with 10 to 20% effect, or you want something that is the gold standard? And so the best study to prove if a supplement truly works would be a randomized clinical trial against estrogen. If you have contraindications to estrogen, yeah, go ahead, do the supplements, because that's all you can do. Though know that there are also prescription drugs, 2 or 3 out there. They're the SERM, select estrogen receptor modulator, selective estrogen receptor modulators. And they can be used for people who can't do estrogen and probably beat the supplements as well. So as I like to say, don't white knuckle it into menopause. Don't half butt it into menopause. Go for the good stuff.
Wonderful. Thank you. So there's another question related to HRT, and it's asking, what would be the downside to getting HRT too early?
Well, this would be per individual, right? So everybody's an individual. The downside would be that you would not have very good cycle control. So when you're perimenopausal and you're menstruating still regularly or fairly regularly, and you're having, and one of the signs is heavier menstruation, menopause hormone therapy does not control the cycle as well as an oral contraceptive. And that still is what we recommend. I would say all menopause experts, consensus-wise, the majority will want to prescribe an oral contraceptive, or at least look at other options such as the IUD with progestogen and adding estradiol on top of that. But oral contraceptives have been tried and true, and they have worked. And again, they have the other benefits as well, as reduction of endometrial cancer, which is actually on the increase in the general population. It also decreases ovarian cancer. So, and then of course, anemia. So there's really a lot of benefit to stay on oral contraceptives. And we are seeing a lot of women talking about bioidentical, I want natural. And of course, I totally understand that. Our ovaries make sex hormones and they make estradiol and they make progesterone. So it does make sense that we'd want to put something natural in our bodies. And it's good that we have now a lot more studies, of course, on bioidentical and replacing our bioidentical hormones. But we also have a lot of studies on oral contraceptives, and we do know that they work.
Wonderful. And talking about oral contraceptives, maybe going to the younger end of the spectrum, one other additional question is, what's the earliest age you would consider prescribing a birth control pill?
So I'm an adolescent medicine specialist, and in general, if you're just doing it for convenience or hashtag periods optional, not because you have bad, evil periods that you're missing, or you have anemia, or you have a platelet dysfunction that every time you bleed, you totally flood the bed. I generally advise people to wait 2 years after their first period, simply because you're still growing in height. And my anecdote is, you know, we are short little Asians in my family and we're trying to get maximum height. And so I told my daughters, unless it's really bad, you know, if it's about height, but theoretically it's just 1 to 2 inches that you might lose because you're still growing. And if you throw the estrogen too soon, then it fuses the growth plate so you don't grow any taller. But if you are missing school, missing work, bleeding like heck, have anemia, then as soon as you get your period, we can turn it off and you can go on a birth control pill. So it could be young people are getting their periods at 10. But 12 is the average age of periods in the United States. And before 10, you could use a GnRH, which is much more expensive. You go see the endocrinologist to turn off your periods for 2 years.
Wonderful. Thank you. And there are comments in the chat about good to know about the Great Flood. People wish they'd known sooner about that. And kind of sharing your what you've been saying about the lack of knowledge out there from providers in this space. But here you have 2 amazing providers, and you have Pandia Health as a platform to engage with them on your one-on-one personal needs. There are a few more questions in the chat, so maybe I'll just pick on 2. There's another question about HRT. Maybe it shows our age group on this call, basically. Is there an age or number of years post-menopause that HRT is not recommended?
That's a very good question. So we do have guidelines, and on telehealth, and most physicians will resort and go and use the guidelines made by the Menopause Society. So what we'd like to do is that within 10 years of your last menstrual period, or age 60, is when we know that we're treating a woman that has fairly, without cardiovascular risks and so forth, that they are the target population to reach. There's this vulnerable period of time where we see the most benefits with menopause hormone therapy, and that's within the window of late perimenopause to transition to several years after menopause. Now, beyond that, we start to get cardiovascular risk just because of age alone and for living and so forth. So beyond the age of 65, if you're already on menopause hormone treatment, the new guidelines are stating you do not have to be discontinued. You could switch over to the transdermal method, which has a better preferred safety profile. And then also to lower the dose. Like, you don't necessarily need to have the same support that you had maybe when you were just transitioning. So you would go with a lower dose. But beyond 65 years of age and initiating hormone replacement or hormone menopause therapy, you'd want to very much see a doctor in person and talk about your individual reasons. And it is also recommended that you have your cardiovascular risk score assessed, that perhaps you need a coronary artery calcium scan done to assess your atherosclerotic risk before starting on menopause hormone treatment. So it's not, a one size fits all. Again, everyone is individual, but on most platforms and most practices, we stay within the guidelines of the Menopause Society, and we, of course, give education as to why someone might want to visit their doctor in person for individual cases. And also, if you have a new onset of hot flashes and you had not had them before, that's also a red flag that you need to see a physician about those symptoms that emerge after years of not having them.
I love that, Dr. Culver, because you're really personalizing care. You're saying, yes, we can use telemedicine appropriately for these certain aspects. But then when you need to go see a physician in person, here's when we recommend. And I love it when experts work within their expertise and with the technology that can support them. And I'm assuming you probably have recommendations potentially to providers in their area as well, that they could go see in person if they can't find access to those providers.
Yeah, we really don't want to take the place of an annual visit, and we really state that. And we want to work with a woman's physician. So a lot of the times, let's say a woman does have some irregular bleeding, or we're concerned about their bleeding pattern, we will state, you need to see your gynecologist. What was your workup? This is what we recommend. And we're working together. Again, in the community, a lot of physicians are not comfortable yet prescribing menopause hormone treatment. So in a way, the patient is acting as an advocate for herself, but also for other women, because they will bring some of the materials that we say, please download this, please read this, bring this to your physician. So it really helps. And a lot of times, taking care of the day-to-day symptoms or adjustments that women may need with their hormone treatment really helps their in-person doctor as well. So I like to think of it as a combined effort. We definitely do not want to take the place of the annual exam. That is so important. And of course, a pelvic exam is always required every year. That's what we would like women to have.
I love it. It's a collaboration. Collaboration saves lives. Carla Shepard, I see your question. And yes, maybe we can touch base afterwards and talk about how we can share this information more broadly into others, because it is extremely helpful. I'm going to take one more question, ask you guys one more question. And then we're going to, respectful of your time and where you have to be, clinical care, wrap up, and I'll hand it over to Bethany, our co-founder. There is a question as relates to studies regarding MSKs, menopause, and breast tissue pain and syndromes. Do you guys have any insights or inputs related to that?
I defer to Dr. Culver.
What does it say? MSK? Where was that?
MSKs.
It's the very last question.
From
Musculoskeletal, I presume.
Oh,
yes, that's.
so the question is, I guess,
and
I'm
assuming, yeah, is it musculoskeletal syndrome, menopause, and breast tissue pain and other syndromes? I guess maybe it's these associated complaints or aspects that maybe pop up as you get older.
Yes. So we do know in perimenopause, we can have all kinds of symptoms because, as Dr. Yen described, our hormones can be fluctuating, high, low. And we do know that sometimes there's a progesterone surge too, which causes painful breasts, and women will find that they have difficulty sleeping on their stomachs, and that's a pretty frequent complaint. When women start hormone replacement or menopause hormone therapy, and they had not, let's say, had their menses for a year or a while, it's like the estradiol and the progesterone are traveling all around the circulation. So I tell women that they might feel like some parts of their body is been reawakened. So yes, there is sometimes an acclimation period when someone starts menopause hormone treatment, as well as oral contraceptives too. There's a period of acclimation. And if things persist for 2 or 3 months, like symptoms, then adjusting dosages, or sometimes occasionally we'll have women use progesterone intravaginally, although that is not an FDA approved route. But we do know through women that have gone through fertility treatments and so forth that progesterone has been given intravaginally, and for some reason, some women do feel like some of their symptoms go down. But again, this is a minority group percentage of patients that have side effects that complain of them. Most women do acclimate and are able to take the medication FDA approved way.
Awesome. Well, thank you both so much for your insights, your expertise, for your work here. Don't suck it up. Stop sucking it up. Yes, absolutely. If you're listening, please visit pandia.com and learn more. And you could even have a consultation with Dr. Culver or Dr. Yan or whomever is going to meet your needs at this time. The chat is blowing up with thank yous and appreciation for this. And if you have additional questions, again, go to the website. And I'm going to turn it over to Bethany to wrap us up. And again, thank you for your time. It's been such a pleasure and so informative.
Thank you, everyone, so much for being here. Dr. Yen, Dr. Culver, that was an incredible discussion. I learned a lot, and I'm sure our audience did too. What a great way to kick off our Women's Digital Health Network webinar series. We hope you will follow the Women's Digital Health Network on LinkedIn, social media as well, because we will be hosting more events like this. And we also encourage you, if you want to make a difference in women's digital health care, to sign up for the Women's Digital Health Network and be an active voice in front of Congress and the regulatory agencies as we start to move our 2025 strategic plan forward. Two of the areas that we are going to be focusing on for 2025 are reimbursement and FDA approvals. So those are some big barriers to women's health care, and we need all the support that we can get. So please consider joining, follow us, and we are so excited to see you at the next event.
Great. Thank you so much. We go to our website, join the network, and go to the website for Pandia and, get your questions answered. Thank you so much again to all our speakers. We really appreciate it, and have a wonderful afternoon.
Thank you.
Thank you.
Bye-bye.